speakers have mentioned, you can bring in images from other devices, and Michael is going to show you two new devices melded together for some advanced PRP techniques.
Good morning. Thanks, Peter. So, we spent a lot of time already talking about diabetes, and I'm going to change course a little bit, and I'm going to talk about retinal vein occlusion. A lot of you know I do a lot of work with retinal vein occlusion, and I do a lot of work with combination therapy. And the problems that we have when we have all these great therapies is not how to make people dry. We're pretty good at that. The problem is when every patient says, how many of these shots do I need and how long is it going to last? And there've been a lot of work about when shots wear off, you've got extensive reswelling of the macula. And there's a lot of theories that talk about the fact that peripheral ischemia is the driving force. So extensive peripheral non-perfusion may be obviously seen in eyes with retinal vein occlusion. The problem is, of course, when you use regular fluorescein angiography, you don't get out that far. Even when you do the 7 fields, you don't do it. So, and depending on the individual, there's going to be some variability, and eyes with more severe ischemia have more macular edema, but they also show greater reduction with treatment. And we ran a study that looked at this using the Optos. So what's interesting, though, is that no matter how much ischemia you have, it doesn't seem to affect the duration of therapy. But we do think they're confounded, and we think there's a VEGF level. So the easy way of explaining this, if you've got peripheral non-perfusion, it's a source of VEGF production, and that will go increasing ischemia, but we're not sure what's driving it. So I'm going to show you a picture of someone. If you look at the concept of ischemia, and you think of it as a spectrum, the most ischemic patients you have are patients with rubeosis. And that's, if you think of your patient with rubeotic glaucoma, the original thought is there's so much ischemia, and that you see it in central retinal artery occlusion, or you'll see it in bad diabetic disease. There's a lot of ischemia, and do lots of PRP. Well, this is a patient that came in with a history of central retinal vein occlusion, and we looked at Optos wide field angiography, and we looked at the fact that when we gave the person anti-VEGF shots, we increased their circulation and decrease their ischemic index. And you can see here, this is the pointer, that basically they start off with an OCT volume and ischemic index of 61.4, and they had rubeosis. You gave them bevacizumab. A month later, the patient comes back, and guess what? This is the original Optos image. So this is all the non-perfused area. It's black and white. And this is the same patient a month later. Notice the increase in circulation. As you have the increase in circulation, you have a reduction of the ischemic index, and the rubeosis has gone away. So we treated this guy every month because his feeling is, I didn't want to do PRP. I don't want to lose my peripheral vision. And you basically saw that the variation of OCT thickness directly correlated with the extent of ischemia. So what happens is when the shots wear off, his ischemic index goes up. When he gives him a shot again, it goes down. And it's bounced around for like 2 years. So the question was what to do with this guy, because this is the ultimate cycle of what happens. Well, we knew that using combination therapy with Ozurdex and anti-VEGF, that it lasts for 4 months. Any way you do it, it comes out. We have statistical significance about the fact that this is reproducible again and again and again, but how do we stop it? So we talked about retinal photocoagulation. The patient said, I don't want to lose any vision. What are your options? Conventional laser has limited planning and treatment. This is where Novolus can make a difference. And my dear friend Dave Brown taught me, we live in Texas, and I pick up one of his analogies. He says, I'm a simple guy. We have a drought all the time. So we have green grass, yellow grass, and brown grass. So the story is when it rains every once in a while, your yellow grass can become green. But you've got areas of your lawn that's always dry. And imagine you have a limited irrigation system. If you could find a way to basically pull out the brown grass and have all that irrigation go to your yellow grass, it would eventually be green. So what we're trying to do by doing PRP, we may stop the VEGF load so you won't have this rebound edema again and again. So here's where Novolus comes. Okay, so what we did was we took the Optos wide field images and we identified the areas of non-perfusion. And you can see in the picture here that this is the yellow grass. So basically, when you have an anti-VEGF shot on board, this area has perfusion, and when it wears off, it goes away. So what they did, using the imaging system with the contact lens, we imaged the entire retina using the Novolus machine. So we had a patient, we put the lens on, and we got pictures. And you can see these are the different pictures that we ended up with. So we got the Novilas images, we have the Optos images. So now we take the Optos images and we take the Novilas images and we overlay them and we register them. And you're going to see the registration process. And what's interesting to note is you watch the registration process, we go point by point with the different vessels. And over time, what's going to happen is remember, if you know the Iceland effect, that basically if you think of a map is the flat map versus the globe. What happens is Iceland gets much smaller on a globe than it is on a map. And you can see as you start registering the images, the eye suddenly changes shape because you're now getting the fact that the eye is not a flat surface, but it's actually a globe. And you can see that over time, these images start to register. So then what's the next thing we do? So what we do is we do image planning. So we basically took these 2 overlaid images and we planned our PRP. We're only going to laser the area that I said, this is the brown grass. This is the area that's always ischemic regardless how many anti-VEGF shots you do. We're not going to go after this area because this area still has viable vision. So the goal is to do the least amount of laser to get the job done. And this is how you do the least amount of laser. And what's interesting is that you're going to pick different patterns, as Michael talked about, to fit the space. So we've got grids and circles and lines, and you can see we're filling up the space. So this is the actual treatment. So I put a lens on, and when you're in the right space, you'll see the grid. And now the laser's kicking along. Pretty simple to see. And and then you need to know, you have to adjust the power and the spot. The spot's already there. You saw quickly, I got some uptakes, I continue it. By the way, this is 1 foot pedal switch, okay? My foot has only gone down once. It's holding it in place. The laser's doing the whole thing. So you're gonna watch it go through the entire process. And then it follows the patterns that I put down before. And that's what you've got when you're done. So this is basically, and you move on. You're doing this quadrant to quadrant to quadrant. And what you're ending up with, maybe, is you plan. This is how you do, this is what we're gonna plan. This is what we're doing. You treat them. You see what you've actually got done. And then you document. And this is the documentation. And then this is right afterwards. So this is the targeted PRP that even though you've got ischemic areas, what it looks like over here because of the fact that the vessels, you're getting peripheral, wide field laser, and you're just doing what you need. And the story is in this patient, we just did, actually I stole Dave's laser about a month ago to do this, so I only have 1 month of follow-up right now, but already even when seeing the patient back, because I knew his cycle was every 2 months, on his first month post-op, he doesn't have all this rubiosis anymore, so he doesn't need another bevacizumab shot. So this is the next step. Obviously, we're working to integrate 2 different types of technology, but the hope is that this is going to be the laser of the future, that by using integrated technology and multi-modalities, this was talked about bringing over the OCTs, and you bring up other wide field imaging systems, you're going to be able to create a better treatment plan that's more precise, that's going to make patients happier. So in a nutshell, Optos wide field imaging can assess monoperfusion. We incorporate them together, and we get planned PRP so we can decrease the rebound edema. But obviously, we need further studies. Thank you very much.